may have a different issue and you may wish to choose that. So what is the evidence around milk? Well, there isn't much, is the honest answer. Most of the studies that have allowed an interval and then assessed gastric contents have actually used black tea or coffee, or often just water or juice. But there was some quite elegant evidence produced by Roger Maltby, who of course is the first person really to challenge that nil by mouth from midnight doctrine so many years ago. Sadly never published, but what they did was they made a model stomach, which basically comprised a glass vessel with a burette tap at the bottom. It contained acid at the normal stomach pH, and then they added to that model stomach milk using little cafeteria-type pots. And when they added 1 pot of milk to the model stomach, then the fluid just simply ran out of the tap perfectly easily, and there was no problem at all. When they added 3 cartons of milk, then the milk and the acid combined, tended to curdle, form small lumps. This blocked the tap, and there was no free flow. So they concluded that 1 or 2 cartons of milk added to coffee would be safe. There are, of course, limitations to that. It's a rigid glass vessel. There's no mixing, there's no churning, and also it's a rigid orifice. There's no ability to stretch, to dilate, so even quite small clumps would get held up. Whereas in the real situation, in the real stomach, you would imagine that small clumps would still pass through and gastric emptying would still be reasonably normal. So I think, again, the evidence from this model is actually quite conservative. We've also got quite a lot of anecdotal evidence from a number of places around the country, and indeed other countries, where patients are allowed to have milk added to their drinks, and to date I'm not aware of anyone who's had a problem as a result of allowing that. And we've certainly been doing it in my hospital for at least 20 years, to my knowledge. Moving on, we have added to our basic recommendation about 2 and 6 hours that patients with obesity, with gastroesophageal reflux, with diabetes, and pregnant women who haven't yet gone into labour can all follow those same guidelines. We have added the caveat to that this is with regards purely to safe fasting intervals, and that obviously there are other aspects in those conditions that may or may not alter the overall management of those patients. The evidence for this is much, much less strong, because quite often these specific groups have been excluded from studies, but there are a few studies, and again a wealth of anecdotal and sort of personal experience that suggests that these conditions don't have a marked effect on gastric emptying. So a weaker recommendation and a weaker level of evidence, and that's clearly shown. We've also recommended that patients should not have their operation cancelled or even delayed simply because they're found, when they come into the hospital, to be chewing gum or sucking a boiled sweet or smoking. And again, this is a little different from some of the other guidance. And we've said that is based, again, solely on the effects of gastric emptying, and we clearly don't encourage patients to smoke. We'd much rather our patients didn't smoke for at least 6 weeks before surgery, let alone a matter of hours, but purely in terms of gastric emptying. The evidence here is a little stronger. It's still not the best evidence, but it's at least grade 1 evidence, and the recommendation is therefore a little stronger as well. Now again, why have we come to these conclusions? Well, we know from several studies, including at least 2 by one of our guidance group members, that the effect of chewing gum is simply to produce oral and gastric secretions, and therefore these secretions will be handled like clear fluid, and therefore will drain from the stomach very quickly in that exponential curve, and don't appear to have any greater effect than drinking. The same really is true of a single boiled sweet, and that is usually the scenario we're faced with in practice. So, you know, some child turns up with a sweet in their mouth. Now, clearly, if they've been knocking back, you know, 2 sandwiches, 3 bags of crisps, and 4 packets of Maltesers or something, that's food. But if they are literally just sucking a single sweet, which is dissolving in the mouth, all you're really doing is giving them a small volume, and I stress small volume, sugary drink. So it's again behaving like a clear fluid, and that isn't really a good criteria for delaying their operation by a whole 6 hours, because it's not solid food, is it? You have to use your common sense. There is a level of intake that is going to be significant and is going to represent solid food, but one sweet ain't that. There are some further recommendations I won't go into in great detail. We have recommended that for infants and children, the guidance is essentially the same, 2 hours for liquids, 6 hours for solids, but we do recognise good evidence that breast milk is cleared from the stomach rather quicker than other species of milk, which is perhaps not surprising because at the end of the day that's what we're designed to handle, and so you only need a 4-hour interval for breast milk, after which the child can still have clear fluids for 2 hours. We also considered the evidence on the routine use of prokinetic agents and H2 antagonists and all of those things. I won't go into the evidence now, but there's no evidence for routine use with the exception of obstetrics. And there is a whole obstetrics section to these guidelines which goes into quite a lot of detail around various regimes recommended around the time of caesarean section, emergency and elective. So again, the evidence on that. And then finally, some advice on oral carbohydrates that you're going to hear from Baz in a minute. The last section we've dealt with, perhaps appropriately, is around the resumption of fluids after surgery. And the guidance there says that adults and children should be allowed to resume drinking as soon as they wish after elective surgery. Again, with a caveat, and that is that we shouldn't insist on it, because we do know that if a patient is feeling slightly queasy or a little nauseous, then forcing fluids on them is actually likely to make that sickness worse, which will have the effect of delaying surgery. And there is good evidence, certainly in the day surgery arena, which is really where this is relevant, that if you insist on patients drinking before they're allowed to be discharged, the only impact of that is to delay discharge and in fact to reduce the number of patients that can be discharged on the day of surgery. It is perfectly safe to let the majority of patients go home if they have chosen not to drink. But likewise, if they wish to drink, there is no reason why they can't straight away. And this is also increasingly being seen now after more major inpatient surgery, in particular colorectal surgery, where patients now, as part of the enhanced recovery program, are often given a drink in the recovery room. The evidence again for this is quite strong, and therefore the recommendation is quite strong too. So that really allows me to conclude on a fairly positive note, which is to tell you that you can basically start drinking anytime you want, and indeed at any age. So I will leave it at that. The guidance will be available soon in the European Journal. We'll do questions when you've heard from the other speakers as well. So